Good evening, everybody. Welcome to the journal club of this month. Um, as is my practice, I have allowed the students to decide what is the topical uh, discussion they would want, and they have chosen among the 4 or 5 papers they showed me. They have showed this one. So let us now start the journal club with Sameer. Over to you, Sameer.
Yeah, thanks. Good evening, everyone. I'll be presenting this month's journal club. So, this is on biolab trial, which is biological versus synthetic mesh in laparoscopic inguinal hernia repair. So, this was a multi-center RCT, which was published in 2025 October in JAMA Surgery, which we know has the highest impact factor and site score. Impact factor of 15.9 and site score of 30.8. The chief investigator of this study was Professor Dr. Marcus, who is a visceral surgeon and has high quality studies regarding hernia repairs and abdominal repairs. And the sponsor of this study were Witten and Ardeke University. The study started from the data like recruitment from 2011 to 2016, and the results were like 2-year follow-up from 2017 to 19, and then data analysis, and finally publication in 2025 October. So the study started with a question in mind: does biological mesh reduce postoperative pain without increasing recurrence compared to synthetic mesh? And the expected outcome was, will biological mesh have a reduced postoperative pain without increasing recurrence? This was backed up by the this one theoretical theory that biological mesh are collagen based and resorbable implants, and they integrate into host tissue, promoting physiological remodeling and avoiding long-term foreign body presence. So theoretically, they should reduce chronic inflammation, lower risk of chronic pain, and better biocompatibility. So as we know, hernias repair is one of the most commonly performed surgical procedures worldwide, with about 13 million operations which are conducted annually, and this represents a major surgical burden, particularly in low and middle income countries. Approximately 30% of these patients will have bilateral disease, making them ideal candidates for comparative studies like this. And laparoscopic repair are the current standard of care now. Uh, Whether it is TAPP or TEP repair, they are already well established approaches, and they reduce postoperative pain, faster recovery, and lower wound infection rates. Both these repair routinely use synthetic mesh, which has a excellent tensile strength and low recurrence rates. However, there are two major complications, which is chronic postoperative pain and hernia recurrence. Uh, the chronic postoperative pain occurs in about 11 to 54% of patients, according to studies, and it is a result from foreign body reaction, chronic inflammation, and nerve entrapment, irritation, and fibrosis. The recurrence, even after the synthetic mesh repair, is usually due to like factors which are patient related. It will be either advanced age, increased like obesity, which causes intra-abdominal pressure, impaired wound healing due to smoking, or microvascular diseases which like diabetes mellitus, which will cause poor healing, and COPD, constipation, connective tissue disorders, which will have a defective collagen, and finally malnutrition, which will cause poor tissue integration. Hernia related factors will be mostly larger defect size, which can have this inadequate coverage or tension, and then recurrent hernias, which will have scarred and distorted anatomy. And mesh-related factors will be inadequate overlap, insufficient tensile strength due to poor mesh quality, incorrect positioning, inadequate fixation. And surgical factors will include again inadequate dissection if the surgeon has missed any hernia, sac, or lipoma, and improper fixation, folding, or wrinkling of mesh. And post-operative factors include early strainous activity, mesh infection, seroma, hematoma, or chronic inflammation, which will weaken the repair site. So, what was the need for this study? Uh, the BioLab trial was designed to address the critical gap, which is by conducting a multi-center randomized trial. There are very few low quality evidence on biological mesh for inguinal hernia repair. Most of them are small case series or retrospective studies, and no large randomized controlled trials directly comparing both the mesh have been done. And it is unclear that whether the biological mesh actually has less pain and less recurrence. And this RCT will guide surgeons for a better guide, like better use for biological mesh. Sir, I'll proceed, sir.
Carry on. So any questions so far? Sameer, what is the accepted recurrence rates after laparoscopic hernia repair? What is the published data say? Sameer,
Sir, 1 to 10%, sir.
anybody? Karthik? No answer? Nikita?
Laparoscopic below 5% is acceptable,
Ah, what is the
whereas open ones,
quoted figure, ma? In large studies, what have they shown?
1 to 4% we have seen, sir. Tap or tap repairs.
Tanya?
Sir, the published data says that only, sir. Up till 5% it is the recurrence rate.
Up to 5% is what is
But if it is
quoted. What is
In
quoted?
Yes, sir, it is what is quoted.
Quoted. Karthik is not there, or is he not answering?
He is not there, sir.
Why? Why is he not
he's traveling right now, sir.
traveling? I thought he had
Like
only.
he said he was traveling to his hometown. Yes.
Anyway, okay. So the
Network is there. Yes, sir.
recurrence rates.
Sir, Shrikant sir has joined, sir.
Srikanth, good evening. Welcome. Srikanth,
Good evening. Good evening.
what do you think is the internationally accepted recurrence rates after laparoscopic hernia repair? Srikanth, did you hear me?
Yeah, what I say, less than 5%.
Less than 5%. But what is the
Open hernia rate should be less than 1%.
1 to 2% level? So, Stephen, today the debate about laparoscopic hernia being the standard of care, I think even European Hernia Society, American Hernia Society has now recommended that laparoscopic hernia be the standard of care. But recurrence rates are still, I think it is still underreported and accepted at 5%. So, I don't know, people seem to lie about their recurrence rates as far as hernia repairs are concerned. And even the seroma, I mean, hematoma rates and all those things are much higher laparoscopic hernia repair compared to open repair. But anyway, that is for another day. So, Sameer, one more question I wanted to ask you. What is self-controlled methodology? Are you going to explain that?
Sir, yes, sir, yes, sir.
Yeah, okay. Carry on.
Yes. So, yeah, for methodology, they have this. They have done the side allocation randomization in which patient was randomized 72
What
hours.
is the heading topic?
The topic is
Biological
versus
mesh versus
synthetic mesh.
Synthetic mesh.
synthetic.
For to looking for long-term recurrence and pain to see
Okay.
if there is any difference. Okay. Sanya, is
So,
Niranjan there?
So sir said he's in a meeting. He'll join in like by 9:30, sir.
Okay, right. Oh, today is what, Monday? Anyway, okay, okay, fine. Carry on, Samir.
yes, sir. So before 72 hours, they were randomized, and the stratification was left to the study center. And this was a double-blinded study in which patient and assessors were blinded. This was conducted for 21 German centers, and it was a self-controlled design. So by self-controlled design, it means that the patient itself is control and like because they have put biological mesh on one side and synthetic mesh on the other side. So this serves as a control and uh, the
Yeah, correct.
yes, sir. On like the patient itself serves as control and the
Control and the case in the
yeah,
study.
yeah, and
Yeah.
the study on yes, sir.
So, what is the advantage of Nikita? What is the advantage of self-controlled study? A self-controlled trial.
Sir, confounding factors are eliminated, sir.
Ah, so
Uh, that
errors
is the
are
main
less.
advantage. Yes,
Errors are less.
yes, sir.
So all the
But it's a
ah,
limitation
what is the limitation?
to recruit the patients, sir. They should have
Bilateral
bilateral
hernia.
issues.
Yeah,
Yes, sir.
but they have done it over a long period of time, so they have actually managed to do it.
Yes, sir.
They've only recruited by patients with bilateral hernia.
Yes, sir.
Okay. Carry on, Samir.
Yes. So for the biomesh, they have used these three types of mesh, which is biodesign, Surgiment, and Tuto mesh, and the respective manufacturers. This is the approximate uh, like price in Indian currency, which uh, it is quoted, but then obviously because it is Germany, so it is covered under healthcare aid, and it ranges from about 2.8 to 6 lakhs for the because they will be using two mesh uh, over here, and the synthetic mesh they have used about some eight kinds of mesh over here. So adult patients with primary bilateral inguinal hernia fit for laparoscopy repair were included, and recurrent hernias, incarcerated, strangulated hernias, and patients with acute systemic infections were excluded. Laparoscopic TEP or TAP repair was a surgical technique, and it was a self-controlled design as we have already discussed. So allocation was if one patient receives biological mesh on one side, the other side will be synthetic mesh, and same technique was used for both the sides. For pain score, it was calculated using the visual analog scale, and time frame was 6 months, and 2 years time frame was given for hernia recurrence. Secondary outcomes such as seroma, hematoma, surgical site infection, and patient satisfactions were also evaluated. So pain assessment was done using visual analog scale. Recurrence detection was mainly clinical plus or minus imaging, ultrasound, CT or MRI. So assessment timing was at discharge 1 week, 6 months, 1 year and 2 years. So the whole overall biolab journey begins pre-operatively when patients were randomized 72 hours before the surgery. So day one will be surgery. Week one will be when they have assessed for early complication. For then 6 months at was when they have evaluated the endpoint one, which was pain intensity, and 2 years was endpoint two, which was recurrence rate. For analysis, they have used like it was intention to treat analysis, and unit of analysis was hernia. Wilcoxon signed rank test was used for continuous data, such as the VAS score, and McNemus test was used for categorical data, such as recurrence, seroma, and complication. And then bone ferrigny correction was done for multiple comparisons. Critics.
Okay. Who is going to do the critique? Ainas?
Yes, sir.
Critique.
So starting with it is published in it's a relevant topic, sir, which is published in a good journal with a good impact factor, sir. And apart from that, it is a recent study, sir, like done recently. So that is also a good point. Sir, it's following this pattern of self-control design, sir. So and again, it is an RCT, so which is a good point, and they have blinded so the surgeon is not blinded, sir, but the patients and the who are interpreting, yes, sir, assessors are blinded, which is a good point. And they are following the principle of intention to treat analysis, sir, which is a good point, sir. So in terms of the cons, like so this is what I found as the pros. And in terms of cons, sir, there is this point. So what they are telling is that they have used three types of biological mesh, sir. Like there are these three different biological mesh, and for the other groups, sir, like they have used nine types of like there are nine meshes that they have stated the types that they have used, the brands. So is that a concern? Like because there's a lot of there's no standardization, sir. That's what I felt was a concern. And like Sameer showed that biological mesh is quite expensive, sir. So if cost analysis would have been done, sir.
Correct.
And follow up also, sir. 2 years for a hernia should be considered as less, sir. Like
yes, 5 years is what is more likely. Yeah.
Yes, sir. That's all, sir.
Good. I think you have covered a lot of it. See, the thing is, with respect to the all the measures that they have used are from very standard companies. So I agree that it would have been better if they had used only one company for the synthetic and one company for the synthetic mesh and the biological mesh. But I don't know whether for whatever reason it was availability in one, because it is a multi-central trial. They might have they might be hamstrung by the fact that the hospitals in that area would only use that particular mesh, something like that. I don't know. They have not explained that. Maybe that is the reason, but there is potential for for the results to be different because of the different type, the same, probably same proline mesh, but manufactured by different companies. Nikita, anything to add to the critique?
No, sir, she had covered most of it, sir.
Ah,
I was also thinking of the same points.
okay. Sanya,
Nothing, sir. She's covered everything.
now these two young girls, have you understood what we are doing so far?
Yes, sir.
Yes, sir.
You understood the process of the journal club. Have you read the
Yes, sir.
journal? Have you read the journal?
Yes, sir. We have read the journal, sir.
Both of you have read the journal. See, you may not understand everything, but unless you make an effort, you will not. So the other thing is, have you read about the three tests that they have used? The McNamara test, the Wilcoxon test, and the Bowen-Ferroni correction. Have you read about it? You may not understand it properly, but have you read it or not?
Sir, we have read through the article, sir, but not the test as.
No, see, I will tell you now. See,
Yes,
the
sir.
purpose of the journal club is to critically analyze the topic that is given to see whether it is relevant paper that we are assessing. Second is it done properly? Is the methodology proper? Third thing is whether the statistics have the right statistical tools been applied to the for, because if you apply the wrong test you may get different results, and you can completely, I would say, mislead the people who are reading it. So you have to apply the correct statistical tests. So for that, every paper that you read, there will be new statistics that, we are not going to become statisticians, but we should know what statistics have they applied and are they right tests that they have applied. And for that, if you keep on reading every time you read a paper, if there is, chi-square test, Wilcoxon test, and Man-Whitney U test, student T test, these are very common. Logistic regression analysis, and all these things are common. The rest of it, you will have different things for different, and this Bern-Ferroni correction also comes quite frequently. So, when there is an intention to treat principle, all of these things you have to read. Every time you read a paper, you read these statistics, you will understand over a period of time. Slowly, you will understand these tests and you will understand whether they have been rightly applied. We are not making you statisticians, but we need to know whether the statistics have been rightly applied. So that is why I asked you that question. So you, from now on, next time when you come for the journal club, you should have come prepared with the because it is available easily on the internet. Okay, right, Sameer, carry on.
Yes.
Sir, Niranjan sir joined, sir.
Niranjan, good evening. Hello.
ಸರ್ ಗುಡ್ ಈವ್ನಿಂಗ್. ಅದು IAGS ಆರ್ಗನೈಸೇಷನ್ ಇದು ಮಿಡ್ಕಾನ್ ಇದೆ ಜೂನ್ ಅಲ್ಲಿ. ಸೊ ಎವ್ರಿ ಮಂಡೇ ಅದ್ರದ್ದು ಮೀಟಿಂಗ್ ಇರುತ್ತೆ. ಸೊ ಎರಡ್ ಕಡೆ ಜಾಯ್ನ್ ಆಗಕ್ಕಾಗಲ್ಲ, ಅದು ಜಸ್ಟ್ ಮುಗಿತದಕ್ಕೆ ಇದೆ ಜಾಯ್ನ್.
No problem. Thank you. ಈ ಪೇಪರ್ they have sent it to you? Have they sent the paper to you?
Yes, ಕಳ್ಸಿದ್ರು.
Okay. So this is the analysis for the synthetic versus biological mesh in terms of pain and recurrence rates. So we have come to the first part, pros and cons. Hedappa.
Yes, sir. So, sir, as discussed, it is a self-controlled design which will minimize the confounding. It is a large randomized multicenter RCT, double blinding, and clinically relevant outcomes. Early follow-up, like for 2 years, it is
Pretty
good.
good,
No, sir.
pretty good. But in
Yes,
terms
sir.
of recurrence, you need it for longer time. Yeah.
Yes. And intention to treat analysis, and they have included patient satisfaction, which is a pro.
Yeah.
Cons, as already discussed, sir, it was like we have seen mass heterogeneity within the groups, and there was no quality of life analysis, cost analysis, and the whole thing about this theoretical advantage of biological mesh is that it can be used for infected and contaminated
Emergency.
cases, and yes, they have
Emergency,
excluded.
correct. Yeah.
Yes, sir.
So they have
They
not
have excluded
included.
incarcerated and emergency.
See, but the problem with that is you are absolutely right. But what is the problem? Can you tell me?
Uh,
See, you are analyzing all of them as elective repairs. So
yes,
suddenly
sir.
emergency becomes a confounding factor. That is one. Second thing is, if you have, there is obvious bias when, because it's very, very rare to have a bilateral hernia becoming incarcerated or obstructed on both sides simultaneously. So it will usually be one side. So if you repair an incarcerated hernia on one side, you will be then taking away your randomization, because you will have to do the biological mesh on that side and you have to do the other thing on the other side. So then your randomization goes for a toss. So that becomes a very significant confounding factor, which is why they have excluded it. Though you are absolutely right in saying that biological mesh perceived advantages was using in emergency and incarcerated situation. Followed? Did you follow that?
Yes, sir. Yes, sir.
Okay, carry on.
Have they had any this thing incarcerated in this?
No, sir. They've excluded, sir.
No. Have they got anything? They have not mentioned.
Illa, it will come on the flow chart or Bharat.
Okay.
Carry on.
Yes, sir. So a total of 900 patients were assessed for eligibility, out of which 375 were excluded and 525 were randomized. 261 patients received biological mesh on the right side and 264 received biological mesh on the left side. And out of which, at the end, 243 were analyzed for primary outcome of pain and 248 were analyzed for primary outcome of pain on the left side. And for recurrence, 229 patients were analyzed on right side and 224 were analyzed for recurrence on the left side. So on overall, there was no significant difference in pain between the two groups. Whereas in like there were high recurrence and seroma in biomass. So this was in total a failed hypothesis because biological mesh failed to show like less pain in comparison to synthetic mesh, both at rest and under strain over the course of follow-up from discharge to 2 years. And whereas in the recurrence, the accumulated recurrence was from starting from 6 months, it was statistically significant for biological mesh, and they had around 53 cases at the end of 2 year follow-up in biological mesh who had recurrence. Also, a multivariate analysis was done, which showed that biological mesh have a 4.53 like risk for recurrence, and high volume center again showed a low recurrence due to experience and caseload. Other factors such as seroma and hematoma, they had no significant p-value. Uh, so for elaborate findings, pain at rest at 6 months and under strain at 6 months was not statistically significant, whereas recurrence at the end of 2 years was statistically significant. It was 11.2% in biological and 2.5% in the synthetic group. For seroma, it was higher in cases of biological mesh and it was statistically significant. Other secondary outcomes such as hematoma, surgical site infection, and the patient satisfaction, which they had, which was a subjective thing, it was comparable between the two groups. So recurrence at time point, 6 months, it was 4.2%. At the end of 1 year, it was 8.1, and at the 12 years, at the 2 years, it was 11.2%, which was all statistically significant. So in total comparison, pain was like there was no difference in pain between the two groups. High recurrence and seroma was seen in biomesh groups. As a
Okay.
critique for the
Now tell us about the McNamara test and for the sake of the at least the undergrad, the new girls. What is the Wilcoxon test, McNamara test, and the Bowen-Ferroni correction?
Sir, Wilcoxon test, like because it is used for paid data, sir, for visual analog scales, and it was because they are continuous and they are not normally distributed. So median difference between the paid observations will be calculated, sir.
Have you read about these things or not?
Sir?
Have you read about all the 3 tests or not?
Yes, sir. Hello, sir?
Hello, sir. Ma'am, can you hear us?
Yeah, I can hear you, but not able to hear, sir.
Sir, let meeting it finish. We'll wait for sir to rejoin, ma'am.
Yes, we'll just wait for 2 minutes. Twinkle.
Call, sir. What happened? Find out.
Yes, sir.
Sir joined, ma'am.
Sorry, I think my laptop suddenly went off. Okay. So Nikita, can you tell us about our Ainas?
Yes, sir. Uh, so for this Bonferroni's correction, uh, so normally what happens is that like we have a significant p-value of less than 0.005, but like when you are testing two outcomes, so basically it means that there is a 5% chance that you can get a false positive result. So when we are testing two outcomes, then there is a possibility that that risk will be doubled. So there'll be like a 10% chance. So when we use the Bonferroni correction, it's just an adjustment that you are making to the p-value. So like the significant threshold, so that the p-value will be less than 0.025 instead of 0.05. So you're basically dividing it by 2, sir. So that you decrease the overall false positive result.
Okay.
Sir, for the Wilcox rank test, sir, so it is used when we are comparing two parameters in the same patient, like they are paired. Uh, the two elements are paired, sir. So you cannot treat them. They are not independent data. And also, that is when these Wilcox sign test rank test comes into picture, sir. Wherein and also when the test is used when the data is skewed, which is it's not normally distributed. So for each patient, you calculate the difference. Like for example, if you're taking the pain score, then you will calculate the difference between each and arrange it from the smallest to largest. And then according to that, the test will tell you whether the the result is either by chance or actually there is a two difference, sir. And
Okay.
so McNemar test is also a non-parametric test, sir, like which is basically used for a categorical data, such as like yes or no, agree, disagree. If the data is in such a way, then that is when you use McNemar test, sir. And it will help in showing the difference, sir, like in between, like supposedly before treatment, after treatment, or between the two pairs. In this case, between the two patient groups, sir, it will help us to analyze that, sir.
So what do they think they have used for the McNamara test for?
Sir, like for
Recurrence,
yes, sir.
What?
recurrent
Like,
seroma and complications.
No, probably McNamara test they have used for yes no business, probably for mainly for patient satisfaction. Because they might have asked the questions, did you like that, operation? I think all those things. which will be yes or no kind of answers. So maybe they have predominantly used, because other tests have been used for recurrence and seroma, but the McNamara test they might have used. They have not actually mentioned it exactly, but probably my guess is that they have used it for patient satisfaction. Okay,
Yes.
carry on. I think all of you, I think Ainas has explained these tests properly, but all of you please go back and read up. Every time, these tests come, it is better to revise so that you know what it may not be make full sense to you, but at least you should have an idea of what these tests are about. Okay, carry on.
Sir, critic, sir, with respect to the
Nikita, critic, we'll start with you.
Yes, sir. First, pro would be the analysis, sir, like intra-patient analysis, going to the same self-control thing,
Okay.
and the follow-up of the, very good follow-up of all the patients. So they out of 491, they followed up most of the patients, and so con would be there is no intra mesh analysis, sir. Though they use different types of meshes, if they had put a separate table for that, it would have made sense if only one of the biological mesh was problematic or all the biological meshes have the same kind of results.
And also, they could have probably done, just because it's a big study, there is a significant number of patients, they could have done TEP and TAP also to show
Yes,
that
sir. No.
there is no difference in terms of the recurrence and seroma and other things between the two
Yes,
groups.
that I was about to ask, sir. Like that was also one of the con because fixation is done in 70% of the cases they mentioned, sir. And in that, most of them they use glue for the fixing part. But the
Okay.
taggers also play a different role in the pain, right, sir? So
Pain,
that
correct.
intra-analysis is not done. Tapper system. Yes.
Correct. Ainas, anything to add?
No, sir. That ma'am covered everything, sir. That's what I
Sir,
have asked.
and
Tanya?
one small doubt, sir. Samir, go back to that console diagram. What does non-compliance mean? So, like they have mentioned, but they did not describe about that. Loss to follow is understandable, sir. But what is non-compliance separately? Like we couldn't make it out, sir. What did they infer
Non-compliance.
to?
Non-compliance with maybe the follow-up or the protocol or whatever. I think they should have actually specified what they meant by non-compliance. But I would guess, Niranjan, what do you think they meant by non-compliance?
Well,
Not
that's what it
sticking
is.
to
Very
the.
vague. They've not. It's not very clear.
Okay, Sameer, show the pros and cons.
yes. Sir, pros will be this intra-patient self-control design analysis and appropriate statistical tests and like predefined margins. And there were lots of patients in recurrence, sir, like about some 20 patients in both the years. And the
But
satisfaction, sir, they have not mentioned like what they have used for satisfaction. They've just told that they
correct.
asked for satisfaction, but there was no like whether it was questionnaire or what they have not mentioned, sir.
Quality of life would have been better, as you said.
Yes.
And satisfaction also, they should have mentioned what test they have used. Was it a Likert scale, or what did they use? Qualitative analysis. Because patient satisfaction becomes a qualitative analysis, right? It's not quantitative. So then you will have to convert it to quantitative by using a Likert scale or something like that. So they have not mentioned that. And I think Nikita told about standardization of fixation also. What do you mean by increased type 2 error?
So same, sir, for satisfaction only. And for this pain and recurrence, so they have not calculated the this uh, sample size, sir. Like only for and only for recurrence it was calculated. For complications and pain, they have not, like, adjustment was not done, sir. So whether the p value, because they have adjusted, will it increase type 2 errors? That was one question.
I'm not clear what you're saying. So tell us what is type 1 error and type 2 error then first.
So type 1 error will be when the the null hypothesis is incorrectly rejected, sir.
Okay, then what is type 2 error?
When it is not the null hypothesis is not rejected.
I think what you need to do is to all of you go back and read, or is anyone going to tell us better? Nikita, type 1, type 2 error.
So type 1 and type 2 usually mean type 1 is false positive. So even if there is no difference, but still showing some kind of difference. But whereas
Okay.
type 2 is false negative, sir. So probably it was useful, but they have showed it as a negative kind. But I didn't actually understand Samir's implication in this thing, sir.
Correct.
We'll discuss.
I don't think,
Yes.
Sameer, you're looking too much into it. I don't think there is any increased risk of type 2 error here. But other things, whatever you have mentioned is right.
Why do you think, Samir, that why I didn't understand? What
Sir,
is your understanding? Like, what are you
sir,
trying to mean by that?
sir, for pain and satisfaction, like fewer patients were analyzed, sir, in respect to recurrence.
Why is
So,
that?
sir,
Why is that? Why was that?
so in the concept diagram, it is already mentioned. They have not mentioned
No,
like
was there
why.
any reason for that?
No, no, they have not mentioned the reasons, sir. Only in the
Okay, so
yes.
okay,
So,
so how will
so,
it increase the type 2 error?
so then the power will be low, no, sir, for those.
Power is the like overall study numbers, no, not for individual this thing.
Yes, sir, for those comparison, they have done Bonferroni correction, and then it will go into much lower power, no, sir.
No. When
So
you
that
use
will,
bone
No. See,
correction,
power means
it will not
overall
change the.
study numbers.
Also, one thing, sir, that here they are telling that they have telling that the null hypothesis is like they are rejecting the study and they are telling that the mesh is not good. So, type 2 error applies when you should have rejected the hypothesis and you are not able to. You say that there is no difference, but actually there is a difference. So it
Correct.
won't apply here, no, sir, because they are telling that it is not a good thing.
Correct. I think
Because
that's right. So, Sameer, your understanding of type 1, type 2 error needs to change. You need to go and study. Okay. Good that you brought it up, but you need to go and study, and then we'll clarify that for you. Okay, go on next.
yes, sir. For discussion, it is one of a kind of study with unique intra-patient self-control design, and this is the first high quality RCT in this specific inguinal hernia repairs. It directly compares the mesh types in the same surgical setting, thereby nullifying the compounding factors. And there was clinically relevant outcomes which they have studied, which is pain, recurrence, and complication. And the study has demonstrated the biomesh failure. Uh, Most likely, it is due to the resorbable nature, which has a loss of long-term structural support, and because there will be collagen remodeling, uh, there will be insufficient. It will be insufficient to maintain the defect closure. And compared to permanent synthetic mesh, these mesh have a low tensile strength, and because they degrade early, it will lead to recurrence before the adequate tissue reinforcement actually starts. So,
So, no,
yes,
wait. No,
yes,
before. Ainas. Hello, Ainas, are you there?
Yes, sir. Yes, sir.
Yeah. So, if you just analyze where we use the biological mesh, do you know
Yes,
where the
sir.
biological meshes are used?
Oh, sir, like you said, sir, in emergency cases, sir, like in contaminated cases, we'll prefer using
Correct.
biological
Contaminated,
measures.
recurrent hernias, patients with the bowel resection, and where you expect the infection and things like that. Emergency situations. That is where biological meshes are used. But then
Yes, sir.
the premise that we use it is there is one at that time the potential for the covering of the abdominal wall and protection to the abdominal wall, but there is a, because it is resorbable, there is a higher risk of recurrence. Though it protects against infection, there is a higher risk of infection for the factors that Sameer just listed out. They get absorbed early, and collagenization doesn't happen that well, and so the continued, as you know, the wound attains its full 85 to 90% of the strength by the end of 1.5 to 2 years. So if the mesh is going to get absorbed before that, there is a high likelihood that there will be recurrence. So actually, though some other people have said that it is equal, but the physiology dictates that recurrence rates are bound to be very high with biological mesh. So actually, this study has actually stated proved the obvious. So the lesson to take is that never use biological mesh in elective cases. In emergency cases, use it, but tell the patient that there is a high chance he will develop the hernia again, and then we will at that time repair it. But for the time being, we are using the biological mesh because we want to save your life and we want to prevent wound complications for the time being. So that should be the take home message as far as this is concerned. Srikanth, what is your opinion?
Yeah, same thing. Nothing.
Niranjan,
Try to
anything to add?
go for anatomical repair.
Correct. Either by anatomical repair, or if you have to use mesh, use biological mesh with the premise. But the problem is they are extremely expensive. So that again precludes its use. Niranjan?
Sir, that is what it is. One, it is very costly, and two, it has high level recurrence. That is why it is not been accepted in a wider setting. So I think if it is better to do either an anatomical repair or in fewer settings where you feel that you have to put a mesh, it has to be in some other plane where like if it is not a completely strangulated bowel where there is just incarceration, it has to be in a different plane
Lane.
with
Yeah.
a regular mesh.
So basically, the use of biological mesh is extremely limited and very situation specific. So it is to be definitely excluded from usage in the regular setting, that is in elective setting. So
The
that
time,
much is definite.
time and again it has been proved. But why did they do this study?
I think just to show that biological meshes are not good anta.
That's
Sometimes
what time and again it has been proved that
I
biological
know,
mesh
but
is not used.
are they correct? But all of them were anecdotal studies, very small case reports, atara. So they have actually done this just to make sure that it will never gain acceptance as a standard of care anta.
For elective cases.
So I think sometimes negative studies are also good because there will always be people who are trying to sell these meshes. Just to shut up the
Correct.
pharmacology,
Pharmacy.
the pharmacy people. Sameer, continue.
So, according to the study, the standard of care remains unbroken. Biological mesh have failed to deliver less pain. They have shown higher seroma and recurrence. Similar studies, which they were also randomized control trial for clean and contaminated, like they've used mesh, biological mesh in ventral hernia repair. Even in this randomized control trial, um, with a primary outcome of hernia recurrence and secondary outcome of surgical site infection and complication, the results were same, significant high recurrence with biological mesh, and there were no significant difference between the groups with regards to surgical site infection. Similar one, which was in JAMA surgery, which was again a multi-center randomized clinical trial. This also showed no significant reduction with respect to surgical site infection in biological mesh, and again higher recurrence in biological mesh group in ventral hernias.
Any reason why seroma is high in biological mesh?
Sameer? Anybody else? Any reason why seroma is high?
Does collagen cause any pull of the fluid, sir, into that area? Like osmotic kind of activity?
Maybe,
No,
potentially. See, as Niranjan said very well, I think basically, I'll come to the final comments, but basically what Niranjan said is very true. The AWR understanding has changed so much now that with any difficult and even complicated hernias, incarcerated hernias and things like that, people have become so good now that they will find a plane which is relatively unaffected and put the mesh in that plane. Or also in situations where there is extreme degree of contamination, we can now use vac therapy to overcome the problem. And once the patient is better and patient is discharged home, they will obviously develop hernia, and then you can repair the hernia in the usual way. So the place for biological mesh has almost completely disappeared, because one, they are extremely expensive, and two, they have proven to be of no benefit in terms of reducing either surgical site infection or seroma formation or recurrence rates. So if affords no advantage and you're spending a hell of a lot of money, there is no point. So I think that argument has now been completely settled. So now one by one, we'll start with Malavika and Mahati. What did you think of the journal club? One, how did Sameer do? And two, what did you think of the paper?
Sir, one
Your
doubt, sir.
understanding. Huh?
Sir, one doubt can I ask?
Yeah.
Sir, despite having this seroma and recurrence, how was this patient satisfaction comparable?
That is why, because they have actually not shown what parameters they have used. So there is potential for, maybe it was probably, you can't take the scientifically the value of that particular parameter cannot be accepted, because unless you show the data and unless you show what actually you have done, first of all, is it a standardized patient satisfaction score like quality of life or whatever, and is it what do you call that, has it been validated? No, you can stitch up your own satisfaction score, but if it is not validated, then it doesn't hold scientific value. So first of all, what study did they use? What type of test did they use for satisfaction, and was it validated? And what were the parameters they studied? If they had, if they claim that this is both are equal, then they should have shown the data for it. So any conclusion without the support of the data in the same study is of no value. So that is why you should discount that particular thing. Okay, Mahati and Malavika, what did you think of the study? What did you think of Sameer's presentation? Quickly, no time.
That the presentation was good, sir. And from the study, it basically highlights that the biological mesh does not reduce the pain and it increases the recurrence, which might be likely due to the loss of strength. And overall, the synthetic mesh remains the standard approach.
Okay, good. That was Malavika, right?
Yes, sir.
Mahati?
So the topic is good, sir, and the journal is also well presented by Sameer sir. Like he thoughtfully kept all the pros and cons also in his perspective and allowed the critics also. It's actually nice, sir.
Okay. Among the postgraduates, one of you, please. Nikita or Likit. Likit has not spoken
Yes,
at all. Likit, where are you, man?
Yes. Hello. Yes, sir. Yes,
Tell
sir.
us.
Sameer sir. Yes, sir. Yes, sir. Sameer sir presented well, sir, but the statistic part would have been better explained. And we'll
No, but did you study? Did you study the statistics?
Sir? Yes, sir, but it was like so too much difficult to understand.
So there is a saying in English: people who live in glass houses should not throw stones at others. So you have not studied, so you can't criticize Sameer for that. Okay, Sanya.
Good study and explained well, sir. But I think Sameer should have been a little more confident. He used to be confident in all his journal clubs. I don't know what happened today to him, sir. But it came out very well at the end, sir.
Srikanth, your final
Yeah,
comments.
good paper, good presentation. It has improved a lot compared to
Niranjan.
previous. At the
Sir,
end
I
of 2
joined in
years
the
only.
middle. I don't know the full this thing, but whatever he presented later was good.
Okay. So, Sameer, I think you presented very well. I don't know why Sanya thinks you were not confident. Only area you were not confident was in the statistics because you probably had not prepared for it. So that you have to accept. But as I tell you, all of you, every paper you whatever, even if it is, chi-square test, please read up about that particular test and see whether it is the right test to have been applied for that particular parameter or data. So that you have to always do. I think apart from that, your presentation was good. I think the theme, the slides, everything was very good, well organized. And the paper also is a good paper because it has actually finally put to rest the argument about usage of biological mesh. So no
Completely
place for
disapproves.
no place for biological meshes. That's all. So overall, very good study, and I think there was good discussion. And thank you, Srikanth, Niranjan, and all the students. So if there are no further questions, we'll call it a day. Thank you. Good night.
Thank you, sir. Good.